All right, so the definition. Symptoms related to problems with your lower urinary tract, your bladder, your prostate, your urethra. LUTS are broadly grouped into symptoms to do with storing or passing of urine. Another definition I found, LUTS, it includes voiding or obstructive symptoms such as hesitancy, poor and or intermittent stream, straining, prolonged micturition, feeling of incomplete bladder emptying, dribbling, etc., and storage or irritative symptoms such as frequency, urgency, urgent incontinence, and nocturia. So, some risk factors or things that cause LUTS in men. BPH, urethral stenosis. A urethral stricture can cause some of these symptoms. Overactive bladder. So we've got the urgency, frequency, nocturia, with or without incontinence. They can be caused from bladder inflammation, CNS disorders, just aging, diabetes, bladder stones. Oftentimes we forget about that. And unfortunately, lately we've been finding more bladder stones in patients who have no neurologic issues, do not do intermittent catheterization, do not have a Foley or suprapubic tube, and we're walking around. Normally, you would not even expect it, and we had a female that had like a golf ball size bladder stone, and so that was really, the doctor was having a hard time diagnosing her until he finally looked inside and was like, oops. And diuretic use. So I just wanted to review, because a lot of times by the time you see these patients, they're already going to be on potential medications, one or two, before maybe they even get to you as a nurse practitioner. Or if you're the urodynamicist, they may be on medications when they come into the urodynamic suite. So we have the alpha blockers, doxazocin, terazosin, tamsulosin, alfuzosin, and silodosin. Kind of have the same ring, don't they? Typically, the latter three are the ones that you'll see used primarily today. They have less side effects, and I think all are generic now, so they're all cost effective. You have the 5-alpha reductase inhibitors, so that's the finasteride and dutasteride, so the alpha blockers relax the smooth muscle of the prostate. The 5-alpha reductase actually shrinks the size of the prostate, and so sometimes then you have combination therapy. Some people prescribe tamsulosin and dutasteride separately, or you can get it combined in Jalin. And there's actually some studies that show that Cialis daily actually helps some of the BPH, lower urinary tract symptoms. I haven't seen that really in a lot of the men that I saw in clinic. They were put on the Cialis, but it just didn't work so well. Or it did work really well, but we couldn't get it covered by the insurance. So then flipping to the overactive bladder medications, just quickly with the anticholinergics, you've got the old oxybutynin, then we go to tolterodine, fesoterodine, trospium, sulfenacin, and darafenacin. Older medications, a lot of drying. You got to really be careful with the dry eyes, dry mouth, constipation. Not as safe in the elderly, can cause increased confusion. So you really want to watch some of the older drugs. But then now we have the beta-3 agonists, mirabegron, that's been around for about 7 years, and now vibegron, that's just been out recently. Luckily, those don't have quite the drying effect. Some do cause some constipation, but really the vibegron, limited side effects, but again, it's brand new, so coverage is not so great. Okay, so how do we evaluate these guys? Most important thing we want to do is get a really, really good history. So you want to know, when are they drinking? What are they drinking? When are the symptoms occurring? Is it daytime frequency or is it really just the nocturia? What kind of medicines are they on? One big thing is that I had a guy that was getting up 4 or 5 times a night, had him on different medicines, couldn't quite get him fixed. And finally I said, okay, let's talk about when are you drinking? What are you drinking? How much are you drinking? When's your evening meal? Because I finally decided, when do you eat your last meal of the day? And then when do you go to bed? And he was eating his last meal a day at 6 p.m. and going to bed at 7 p.m. Well, if you're gonna have, of course he's having a big tall glass of tea or something like that, you're gonna be going. And then I'm like, well, how early do you wake up? And he's in bed for 12, 13 hours. I'm like, you know what? You're gonna get up. So sometimes we have to really ask those questions for realistic expectations too. Physical exam. So you really want to check them out. You want to do the rectal exam. You want to feel the size of the prostate. Urinalysis, cystoscopy. Oftentimes it's very good to do that test, even though men do not like cystoscopy. They're going to do everything that under their power to prevent cystoscopy. Even sometimes the doctors are like, Gina, why are you sending this guy to me for a cysto? Because he needs one, I don't do cystoscopies, or I didn't do cystoscopies in my clinic because there was enough docs they felt like the APPs didn't need to do them. So then they would get mad at me when I would send them for cystoscopy. But it really, you got to see that prostate. You got to know what's going on. You may need to do renal ultrasound. You want to definitely get a PVR. You may need urine cultures. Definitely, you want to get a voiding diary. And if you're really going for urodynamics on these patients, we require voiding diaries before every urodynamic testing. Getting an IPSS symptom score, so important as well for me. The first time I'm seeing the gentleman to get an idea, that in itself helps me decide, all right, are your symptoms more bladder or are they more prostate? Are they the overactive, the urgency frequency, or are they slow stream, straining, hesitancy? Then when it's still, you're just not sure what to do, got the urodynamics and the UroCuff. So here's an example of an IPSS symptom score, and as you know on there, it talks about, do you feel like you don't empty your bladder all the way? Do you have frequency? Do you have intermittency, urgency, weak stream, getting up at night, dribbling? On the IPSS symptom score in our practice that we would give out, it actually had at the bottom, would you be interested in a minimally invasive procedure to help fix your symptoms, to try to help get them towards like the UroCuff. Excuse me, not UroCuff, UroLift. All right, so now we're going to move on to just a little bit about what is urodynamics. Hopefully you all know what it is, but it's really the study and documentation of the factors involved in the filling, storage, and transportation and evacuation of urine. So we want to see what is going on inside of the bladder as the bladder is filling, but also as the bladder is squeezing to get that urine out. So these are the groups of procedures considered urodynamics. So you've got the uroflow, the cystometrogram, you've got the intra-abdominal pressure, the urethra pressure profile if you do it, the Truss or leak point pressure. You can have a Valsalva leak point pressure. You have the pressure flow studies. You do check post-void residual at the end and after a uroflow, and you would do an EMG as well. Now you may not get to do these on every single test. My urologists, they didn't do UPPs, but the urogynecologists do UPPs. There was a big, argument of, is it necessary, is it not necessary for the urologists? They didn't do it, so I never actually learned how to do UPPs.